Ken, there was a mention of you earlier because somebody you well know said, I now Binmoeller this lesion. So,
I love that. Yes.
You've been Binmoellered.
In Europe, they call the angioplasty dottering, right?
Yes,
Named after Charles' daughter.
Yes.
So I feel quite honored to have someone say I Binmoellered the lesion.
That's your claim to fame.
So this was, we have a 69-year-old female. And I think this is such a educational case for everybody because she had been undergoing hemocolts every year with her primary, and it was consistently negative. And because of that, she did not have a screening colonoscopy. And she has no family history of colon cancer. But then last year, or a few months ago actually, her physician recommended a Cologuard. And the Cologuard was positive. And so then she was convinced to undergo colonoscopy. And she's found to have this lesion here in the ascending colon. It's the proximal ascending. It was biopsied and found to be an SSA. Now you're seeing the lesion right now, and you don't need a biopsy to diagnose this lesion as an SSA because you can see the mucus cap. There's also the tattoo that was made. I'm just hoping that tattoo is not going too far underneath the SSA. You can see it's a little bluish here. And this is, by the way, all underwater view. So I have intubated the cecum to the cecum using the water exchange method so that I don't have any gas that I have to deal with. I don't have to remove gas in order to submerge for underwater resection. So this is all underwater, and hopefully I won't have to put the gas on. So what I'd like to demonstrate today are a few things. Firstly, this is an adult colonoscope. So it has a large channel, and I prefer that because I like to be able to suction alongside an instrument. For example, I have here my snare already inserted. And I have better suction, but more importantly, I have near focus. So the near focus is on right now, and you can see when you go up close like this, it really is helpful to have that near focus. And if you put the NBI on, then you can actually see the margins of this SSA much more clearly. The SSA appears a little bit more greenish, right? It's got a lighter color compared to the surrounding mucosa. So the problem with SSAs is they have indistinct margins, and you really need to mark the perimeter. So what I like to do is make diathermic dots around the perimeter first. That way I know that I've got the entire lesion out, and my goal is en bloc resection. So really, we do strive always to remove these lesions en bloc if possible. Sometimes we're not successful, and we need to do what I call trimming. I don't really consider that piecemeal because the intent is en bloc. Now I want to show you the technique how we make the diathermic markings with the snare. So this is just a standard snare. In this case, I'm using the Boston Scientific Captivator 2. So my assistant, Jeannie, is going to advance the snare out, my nurse, and you'll see the snare tip come out. So it's coming out now, you see it. Then she's going to recess the snare into the catheter so that you don't see the snare. So I don't want to make holes into the mucosa. I just want to make some dots. And now I'm underwater and using soft coag. So I have soft coag settings on my generator. So we'll just confirm that. Soft coag 4.5, the generator's over here. Now I'm just going to make some little dots. So you can see I just step on the pedal like this and you see that dot. Very nice and crisp. And then a dot here. And I'm just looking where the mucosa is normal. The mucosa is normal where it looks like chicken skin. It's just round, round pits. That's the normal. So there's another one.
Ken, this is Maria.
Yes. Hi, Maria. Wonderful to see you again.
Hi, the same. Are you using saline into the...
Oh, yes. It's always saline. Now, I understand, Ed Despot came up with this term site, saline immersion therapeutic endoscopy or something like that. But we always use saline, so we call it underwater, but it's not really water, right? It's saline. But, you know, we call the ocean water, and it's saline too, so it's not completely wrong. Now, this is a difficult lesion because of its location on the wall. So we can see here a little bit more distant here that I'm going to have to do this, and I'm just falling back. This was a very difficult intubation of the cecum. But I want you to see how the NBI, I love to do this with NBI simply because I can see the margins better. And if you go up close, you can see my dot is outside of the SSA, right? That way, now this isn't ESD afterwards. I don't have to put these dots within 1 to 2 millimeters. I just want to know that when I open my snare is around the circumference. Now I used I have a 33 millimeter here, but maybe I'll use a smaller one. You don't want to use a snare that's too big because you make life just more difficult. You can see that with the water jet channel. So the other thing is you need to have, I have a pump for infusion of water through my water jet channel. That water jet channel is so critical for underwater because it really allows you to interface and interrogate the tissue. It's actually offering another dimension that you don't have when you use gas. All right, so I think I've got my my dots around most of the perimeter. It's kind of hard to get back here, but when you have this floating effect, then it's easier to get to the proximal side or the far side of the lesion than when you use gas. So things just kind of float up into view. You see the classic mucus cap here, right?
May I ask you something, Ken?
Please.
Yes. How much saline or water do you infuse? How long does it take? How much do people need to infuse to make sure that they are having the effect that you want?
So it's all based on how it looks. So remember, the water saline does distend as well. So we don't want to distend too much. You're never going to distend like you will with gas, of course. But you still can distend quite significantly with water. So I would say what you're doing, and you'll see here, the idea is to collapse the lumen to do what I call the water pool, to bring the mucosal bearing lesion into the snare. So you're trying to maximize the real estate that you can capture in your snare. And when you have a large lesion, let's say 4-5 centimeters, you have only a 33 millimeter snare, but with the infolding, with the collapsing of the lesion, the collapse of the lumen, you can bring that 4 or 5 centimeter large lesion into the snare and get an en bloc resection. So this is, again, why you need to use an adult colonoscope. If you use a pediatric colonoscope, you don't have the near focus, and you don't have the ability to suck alongside your instrument like you can with an adult colonoscope. That, of course, has to be the Q type with the near focus. All right, so now I can take the near focus off for a moment, right? And let's just open the snare up. I want to show you how it looks. So the first step is, now ideally, I want this at 6 o'clock. I don't think I'm going to get this at 6 o'clock because of the location, but let me try. Before close it again, Jeannie, let me just try, because ideally I want it at 6 o'clock. Let's see if I can accomplish that. I'll try. And let's kind of hold it there. Now, if I put it like this, you can see I'm just seeing the front edge and I'm not seeing the back edge. So what I'm going to need is really to get that back edge to float up if I'm going to capture this completely. Okay, open the snare. So this is a better approach because I have it at 6 o'clock, but the disadvantage is I don't have the overview of the lesion as nicely. So you see how the snare is open. I can see the distal tip very nicely. I have my okay, I just got a message. I have 23 more minutes. Now, I want you to see here how I'm going to go on the near focus again. All right, the snare is open. You see the backside. Now, sometimes when I can't get the backside to float up, I'll use the tip-in technique, which is where I will inject outside of the lesion, never through the lesion, and then I will impact or tunnel the tip of the snare into a submucosal bleb. So that could be a viscous solution, just saline, make a little tunnel with the tip, impact the tip, then that anchors the tip on the backside so that the tip, the distal end, doesn't flip up. But hopefully that won't be necessary. You can see it's already starting to float, but you can see in the distance here, if I take the near focus, I'm going through these steps very slowly because I want to show you how you need to make sure that the tip is as flat as possible if you want to get this entire lesion on block. And if you want to do it at 6 o'clock, I'm going to have to rotate. Now these dots are helping orient me so that I know whether I'm getting the right and the left side of my snare over the lesion. Okay? So very slowly rotating. Yes?
Do you think that a cap could help you at some point?
Oh, yes. Well, I have a cap on. You just don't see it.
Okay.
Because we're magnified, right? So you don't see the cap. But if I put gas in, you would see the cap. The cap is there, and I always use a cap. All right, so now, see how things are already floating up very nicely? Now, you have to always have the Force with you, right? We're all Star Wars fans here. So the Force be with us now. We don't see it, but you have to feel that you're in a good position, and then you use these maneuvers to maximize your capture. So there's to and fro. That's obvious, right? To and fro. And then there's torque and crimp. So you're torquing and then you're going to crimp. You can see that the proximal end of my snare is in great position, right? And you can see that I have the dots. I think my snare is around the dots, on the perimeter of the dots. So now I kind of push in and I do the jiggle. We love the jiggle. So when you jiggle like this, see how it kind of goes further up into the lumen? Jiggle, jiggle, jiggle. And the most important I want to say is you need patience. Don't do this quickly. ESD will take you, 2 hours. So give yourself a little time. All right, so jiggle, 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 and now my nurse is going to slowly start to close. You don't want to suck too much, but I do a gentle water pull, and I give water while I'm closing, and I want to maximize the heat sink effect. And I'm torquing to try to, that torque also helps. See, when I torque rightward, it pushes the lesion further up into my snare. See this? It's like a jacking back and forth like this. All right, my assistant is holding my scope. Close, Jeannie. The Force be with us now, hopefully. And when she's tight. Then I'm going to sort of pull back, release. She's holding the lesion, that's all. We're not going to cut, we're just pulling back. My scope is looped like nuts because this is a very redundant colon. Believe me, it was not easy getting here. And now I'm giving water, gas, to look and see, and what I'm looking at is the color. I'm seeing, is this turning violaceous as an indication whether I'm strangulating the lesion and to give me a sense as to whether I've got the entire lesion en bloc. All right? So I'm just going to do what we call the rotisserie because we love French chicken. So here I'm just going to move back and forth and sort of see. And I think this looks pretty good. I like this, right? I took my time. Now the next thing is very important. Our settings, where we switch to the vial 3 now. So our settings are auto cut, always auto cut, but we're using 1.6. Now our former settings with the vial 300 were auto cut effect 5, so that we have a little bit more coagulation, and 80 watts. But this apparently is the conversion. Having said that, it's a little different. So we're getting used to this. We just got the vial 3. So let's see how this works. Now the next thing is you want to wait. The nurse is just holding the snare closed. We're watching, and we're going to wait till we see some bubbles, and we see things turn a little white. right? The nurse is not slicing through. And I want my nurse to do this. I've trained her. She knows what to look out for. I know there are some that love to do everything themselves. They are true single operator everything. But I believe that as endoscopy evolves, it is becoming a two-operator procedure. So my nurse here is like an operator. And so she's looking for the bubbles, for the white. When it's turning white, then she cuts through, all right? And then that's when we know to resect. And why is this? Because if she just, closes the snare right away when I step on the pedal, then you're going to cut right through because I'm on auto cut, right? So you need to have this coordinated and timed. And that's how you can get away using auto cut, which minimizes the coagulation injury. All right, so now I'm ready, yellow pedal, right? And we'll see how this looks now. All right, Jeannie, are you ready? And while she cuts, by the way, I'm giving water because I want to maximize the heat sink effect. That means we're not getting thermal injury into the depth. We're keeping it superficial. But we have saline, which is giving us good conduction. All right, let's do it.
You have both feet present.
Okay, I'm just stepping on the pedal. You see it's turning white. She cuts through now. Cut through. And it's through. Right,
Fantastic.
Jeannie? All right, so let's look. Now, one second. No, we're going to look first because, you see, this was tattooed. And what that means is there's scar. And I hate scar. We don't want scar. And the time you get complications and perforations is when there's scar. And I tell you, ink makes scar tissue, horrendous scar tissue sometimes. So now I'm going to start looking. And look at this. It's black. This is the black hole. Now, if you didn't know what to look for, you would think, oh my God, I just perforated. How horrible. No, you didn't perforate. That is the endoscopist, well-intentioned, thinking I, Dr. Binmoeller, cannot find this SSA, and therefore I have to tattoo it for the doctor to find it. Or maybe the endoscopist thought, I'm going to send this patient to the surgeon, and I have to tattoo it for the surgeon. This endoscopist did me no favor by tattooing. Look at this. This thing is black in there. Now, I'm just giving water now to look at the margins. And what am I looking for? I don't want to see any dots. I made the dots to know if I got an en bloc resection. You're saying, oh, it looks so small. This isn't 3-4 centimeters, although the lesion was. No, because it's contracted. But now I'm going to give gas. All right, so now we turn the gas on. Now, you see this? I just want you, don't forget this picture. Please, everybody, don't forget this picture. Never tattoo. Never tattoo. But if you have to tattoo, 3 centimeters away on the opposite wall. But I guarantee you, the tattoo spreads so easily.
Hi, Ken.
Would you
Can you
agree,
hear us in the
Maria?
studio?
Yes.
Hi, Ken. So, really great demonstration there. I was thinking about what you were saying about the operator, single operator, dual operator. And isn't it really important to have that haptic feedback to be able to close the snare yourself and make this assessment with fibrosis? Because it's really hard, even though you may have...
Jeannie has been with me forever. Jeannie, come
I
here.
know.
She's been with me for 20 years. We've done, thousands of these. No, you don't need that haptic. You need an assistant. And I think in the future, we'll call these endoscopy assistants,
what
right?
If you don't have a genie?
Practitioners.
What if you don't have a genie with you? You're working with someone.
Then you get yourself a genie. You train. You don't have the nurse du jour who's doing screening colons all day and only knows how to give you a forceps or a little snare. No, you need an advanced endoscopy. You shouldn't be doing these procedures if you don't have an advanced endoscopy unit. Endoscopy has evolved, and we need to separate now the routine endoscopy from the advanced complex endoscopy. Now look at this. Now with gas, you can see the surface area is getting much bigger, right? This is what you deal with when you try to do it with gas. All right, so now give me the, we're going to close this, all right? And you can, look, the margins are clean. I guarantee you I got it out on block. But now I'm going to close this lesion because I have a, yes?
Please,
Thomas?
listen to my question, please.
Yes,
so
I'm
this,
listening.
This,
Let me have that.
no doubt, this was a Binmoeller 10. What about margin coagulation? Is that already done here?
No,
or?
I never do that because I put the dots there. I know.
Okay.
And it's coagulated. Look, I did the margin coagulation. It's done. You see that?
Okay, good.
I never coagulate the margins. Now, you can do it. Let me show you how to do margin coagulation. Do we have just 3 minutes? Okay, you want to do margin coagulation? Be my guest. Do it. If you want to
I was just,
but it's an en bloc resection anyway.
I was just asking, maybe next year we bring you together with Michael Berg, and that's going to be an interesting discussion.
Because, it's because endoscopy is operator dependent, all right? So if you
Very true.
are not certain about your margins, if you haven't marked your margins, if you didn't do the diathermic dots that I did, if you don't have near focus, if you don't know how to look for residual, then I agree. Then you have to do something extra. If you want to do the margins, you can do it with the tip of your snare. I like to do that if I do that. And I might do that when I see that my dots are there, okay?
Yeah.
And
this was at a block resection. So anyway, there is no, that's not the margin has to be done when it is a piecemeal resection. Here you did a nice in block resection. So we are not fearing residual tumor.
Soft coag. You want to do margins?
No, I was just, Ken, I was just asking, and we are perfectly happy with your reply. And would also be happy.
Give me the DAT. All right, I'm going to show you something that'll, this is, Jerry Way, right? My hero, Jerry Way.
Yes.
Jerry Way would say, I'm going to show you something that'll knock your socks off.
Yes. Yeah.
I love that expression.
Magic. Do magic,
I hope
please.
I can knock your socks off with this. Give me a DAT quickly because we don't have time. The DAT is the dual action tissue. And this is what I'm using. I don't use clips anymore, but hopefully I can demonstrate it because usually I do this underwater. So I don't even give any gas. I just wanted to show you how the area expands, all right? This is much bigger area than what you saw. You have 2 minutes for me to show you this?
Yes, absolutely. We want to see innovations, and that's one.
Good. This is innovation, all right? The idea is independently actuated legs. Actually, I patented this concept over 10 years ago. This isn't a patent for this device, though, but the concept of independently actuated legs is what we're talking about here. All right, so, because I thought a long time ago, you have to control the prongs independent of one another. So it's like the twin grasper, really, for those of you that are familiar with the Avesco twin grasper, but the twin grasper was designed for a different purpose. Now you see there is gold and there is silver, independently actuated legs. What you want is to grab the distal margin, the far away margin, with one of the prongs, close, and there's a post in the middle. All right, and you'll see this. Open it, Jeannie, because this is actually a good orientation. Okay, open the gold. So I say open gold, and this is the yellow is equivalent to the gold. You see the post in the middle? Now what you want to do is dig that post into the submucosa, and you want to be able to grab the mucosa. So this can be a little tricky, especially here. See, I'm in this stupid position here. One moment. I have my assistant trying to help. And underwater is great because you can see it's partially underwater because it floats up. And I dig it in. You let it pleat. You let it infold a little bit. Close, Jeannie. Close. All right. Now I've got that margin. See? And it's like, it's like a flat alligator teeth surface. All right. Very, very firm. Now I'm going to take this surface and I'm going to pull it like a sheet. All right. I want to cover this lesion up. So I'm slowly pulling back to the opposite margin like this, very slowly. And I want to make sure I clear the edge towards me, all right? The proximal edge in this case. All right, now once I'm clear, now I open the silver up, right? And you can see underwater makes it easier. Maybe I should just stay underwater, but here, because I was using water. Now, this is the tricky part. You need some skill because now I've got to capture, and I don't know exactly where that silver one is now. It's the bottom one, but I see I have an idea because there's that fin. You see the fin there? It jumps up. So I know on the opposite side is the prong, is the other clip. Okay, now close that one now, Jeannie. All right, now I'm just going to look, give a little gas, put the gas on. Put the gas on. So we turn the gas off, I guess. And I'm just going to look and see whether it looks like I got both margins together, right? And you'll see it if it looks good. Go. Deploy. All right, that's deploy. Now look at this. See, I got both edges nicely together. Boom. So right in the middle, at the area of the largest diameter, I pull the edges together like pulling a blanket over the lesion. Why do I not like clips generally? Because you're going to get what I call the bridge. You get the submucosa and the muscle caught between the mucosal margins. I don't like that. I want to have the submucosa and the muscle below the blanket. Then you can just take a standard clip if you want. So Jeannie, give me a standard, maybe a 16. You can use a 16.
Why don't you like it? Why you don't like to have the submucosa and the muscle? Why?
Because I do not want that bridge. Because you'll get bleeding. Where are the blood vessels? The blood vessels are in the muscle, really. That's where the bleeding comes from. You see? So, right, we know this from Poland. That's where the vessels are either above in SM3 and the muscle, because muscle is very vascular, or the mucosa. That's why when we're doing POEM underwater, I stay in the middle lane. Like when I drive on the highway, stay in the middle lane, it's the safest. Below SM1, above SM3. All right, here we go. This is just a standard clip. And clips are hard to maneuver. You'll spend way more time. You saw how I was able to deploy this DAT clip so fast. And then now I'm going to put a standard clip, but you're going to see I'm going to struggle. And so now I just use DAT clips for the most part. But these clips are really marvelous. You see there's still a gap there, right? And I close all my lesions completely. But let me push this out just to show you. And I'll try to close that edge. So I try to close the upper and the lower margins aside from where the DAT is with regular clips. I don't even know whether there's a cost advantage. So let's try to see how it's. I got to get into perfect position now with the clip. I've got to open it up. Jeannie, open. And then I try to do what I call the forklift, which is the prong below. I try to dig in, right? And then I push in, and then I try to close the other one. But sometimes it's hard to close or it slips off, right? Look, I'm pushing in. Close, Jeannie. Close. See, it got it somewhat. Deploy. It's okay. It's not great. There's a little, you see how you got that some mucosa kind of in there? So it's just not, it's not ideal. It's closer, but it's not ideal. And I want it to look like a surgeon closed this with sutures. You know, we should follow all the surgical principles. The surgeon's not going to suture and have it look like this.
But
why should we do that?
Ken?
Yes.
I think that's another negative consequence of the tattooing. Because it's hard and firm and it's more difficult to close as a consequence. Don't you think so?
Let me tell you, if I could leave one message for everyone,
yes.
Don't tattoo. Do not tattoo. Describe how many folds the lesion is from a landmark. Right? This lesion is in the proximal ascending. The doctor could have said, the endoscopist, it's 2 folds from the IC valve. Well, then I know where to look. That's how it should have been done. So do not tattoo, and for God's sake, there's some people that are actually injecting India ink to do a submucosal lift. I've seen this. It's insane. And the other thing is, please don't even biopsy. Really, do you need to give me one more clip. Do you really need to biopsy something that's such an obvious SSA? You don't need that. That's crazy.
I think.
And then the other argument for biopsy is, it could be cancer. No, cancer itself is not a contraindication to EMR or ESD, right?
Ken, we couldn't agree more, especially if you want to make the therapeutic endoscopy's life difficult too.
I'm sorry, if you want to what? Make it
difficult? If you want to make the therapeutic endoscopist's life difficult, then tattoo.
Yes. Oh, yes. Make it difficult, and then you're cursing after, you're going, why did... Now I'm going to try this forklift again. See, the problem with standard clips is here. The proximal, the lower one, looks great. But how do I get that top one there where I want it, right? And I got to kind of suck, trying to bring it in. And then the nurse may have, the assistant may have trouble closing it. Try to close. Jeannie, try to close. Okay, it's not bad. Deploy. See, she's so, that's Jeannie. So look at that, looks great. Okay, now I'm going to grab my lesion and come out, and we're done.
Good,
and
great.
I will pin it afterwards nicely, and I have basically saved myself 2 hours, because I tell you, if I did ESD, at least for us Westerners, maybe the Japanese can do it faster, but the Japanese did this study. They compared underwater EMR with ESD. Underwater EMR took 6 minutes. ESD took over 60 minutes, right? So, and that's Japanese. So there's a significant time savings, but more importantly, they found that the R0 resection rate, R0, was equivalent. In other words, underwater EMR was non-inferior to ESD. I love ESD. I do ESD. I'm not against ESD. But I tell you, in the colon, ESD is no fun. It's all mobile, turning around. It's even so hard for me to maneuver my scope to do underwater. Man, imagine trying to do ESD then. It's even harder. So I think ESD, I do it in the rectum. I do it esophagus for Barrett's, high-grade dysplasia, carcinoma inside, all that. Yes, wonderful. But I do not do ESD in the colon.
I think
that's a good advice as well.
Yeah.
Good conclusion.
I think most people would agree, except for the French maybe, but that's a discussion perhaps for next year. Ken, thank you so much for this impressive demonstration of how to Binmoeller a colonic polyp. Thank you.
Okay.
Good. So
danke. Okay,
Pleasure.
See you, Thomas. It was wonderful to chat with you. And Maria, was great to see you again on the screen. Oh, there's my lesion. And look at that. You can see the dots around it, too. If you look, they're infolded. Look at this big lesion here. It's all infolded. I'm going to grab it, suck it into my cap. See the cap now? You see the cap, Maria?
Yes,
you thought there was no cap. There's the cap. You just don't see it underwater. Okay, and I just pull this baby out, and we'll pin it to the board, and it is indistinguishable from ESD. It'll look the same.
Yes. Okay, Ken.
Thank you.
Bravo. We love the cap. We love you. And have a nice afternoon.